Hi, I'm John Mascarenhas from the Icahn School of Medicine at Mount Sinai, New York, and I'm here to talk about treatment options for patients with intermediate and high-risk myelofibrosis. This will encompass patients with primary myelofibrosis or patients with post-ET, post-PV myelofibrosis. So in the United States, using the NCCN guidelines, there are treatment decision nodes that are primarily based on risk scores. So intermediate and high risk are typically lumped together, and then platelet count. So less than 50,000 takes you in one direction, greater than 50,000 takes you in another direction. The treatment goals for myelofibrosis tend to be largely improving spleen and symptom burden, and those are goals that are amenable to JAK inhibition, and we'll talk about those agents, or not always mutually exclusive, but sometimes mutually exclusive, the treatment of anemia, where the patient has more of a bone marrow failure state. So for the patients who have strictly anemia as their major complaint, this could be even transfusion-dependent anemia, but lack the significant spleen and symptom aspect, then we typically check a erythropoietin level. If it is below 500, in my opinion, below 200, one could trial ESAs, erythropoiesis stimulating agents, such as Procrit, Aranesp, or Retacrit. Or if the patient doesn't respond or has an elevated EPO level, then we typically would rely on drugs such as danazol or immunomodulatory drugs such as thalidomide, lenalidomide, or even low-dose pomalidomide. Collectively, all of these drugs have a response rate of approximately 20 to 30% across trials, and often are not durable or can be limited by toxicity of the agent. Increasingly, we are using luspatercept, the activin ligand trap, off-label, still under clinical investigation, in combination with a JAK inhibitor when anemia is present and unmet. Additionally, there are a number of different drugs that are in clinical development, such as ALK2 inhibitors that reduce phospho-SPAD signaling and ultimately affect hepcidin expression and iron availability for erythropoiesis. This is a really interesting area of clinical development for drugs that could be used alone or in combination with JAK inhibitors to offset both disease and treatment-related anemia. But if we're talking about the bulk of patients with myelofibrosis that have treatment goals of alleviating systemic symptoms that are driven by cytokine signaling or spleen that's causing discomfort, early satiety, or affecting movement and functionality, we typically employ JAK inhibitors. For patients with platelet counts less than 50,000 by label, pacritinib is the preferred JAK inhibitor. This is a JAK2, IRAK1, FLT3 inhibitor that also inhibits ACVR1, and in clinical testing has been demonstrated to provide spleen and symptom benefit in the setting of cytopenic myelofibrosis phenotype, so the patients with low blood counts. These tend to be patients with primary myelofibrosis, also with a low JAK2 allele burden or JAK2 wild type, and often have other complicating mutations and subclonal mutations that involve spliceosome or epigenetic modifiers. These patients, unfortunately, tend to do worse, and pacritinib is a nice option to address those issues. Clinical trials always considered an option as well, and I should always point that out because this area remains an unmet need. And clinical trials could be anything from small molecule inhibitors to immunotherapies to even transplant. And I should point out that transplant is an option that should be considered for anyone with intermediate and high-risk disease that is typically under the age of 70, but that's not a hard stop. Patients that don't have significant competing comorbidities and have the wherewithal and interest for a stem cell transplantation, which holds an intrinsic risk up front, but does hold the potential for cure for these patients with advanced disease. So that's, I think, an option that is probably underutilized and should be discussed with patients early on and referral to transplant specialists to have that discussion. Ideally, transplant for myelofibrosis, given its complexity, should be done at centers of excellence where there's a high volume and experience with myelofibrosis. For the majority of patients that have platelet counts in excess of 50,000 and are not moving to transplant immediately or eventually, The JAK inhibitors that are now commercially available in the US include ruxolitinib since 2011, fedratinib since 2019, and then category 2B would be pacritinib, and now the recently approved category 2A momelotinib, which is a JAK1/2 ACVR1 inhibitor. All of these agents have data up front, although the bulk of the data and experience for over 10 years in the commercial space has been with ruxolitinib. That tends to be the first drug or first JAK inhibitor that's used to address spleen and symptom burden in patients. We know from a number of clinical trials, this is a very effective drug. It doesn't necessarily affect the clonal nature of the disease and induce remissions, but it can induce significant spleen and symptom benefit for the majority of patients that are treated. However, the durability of that benefit is limited to a median of approximately 3 years, and by 5 years, 85% of patients have discontinued therapy. And we know from multiple studies that the outcomes of patients who have failed ruxolitinib is unfortunately poor, with a median survival of approximately 12 to 15 months. This represents an unmet need. It also represents an opportunity to sequence JAK inhibitors, and there's data for that, including fedratinib from the Jakarta-2 study, in which a third of the patients can enjoy spleen and symptom benefit even after failing ruxolitinib in the front line. So this is an option that should be considered, particularly when clinical trials are not available for the patient. And this is for patients with platelet counts greater than 50,000. For patients less than 50,000 or irrespective of platelet count, pacritinib as a category 2B is an option, and this is a very good option for patients, particularly with the cytopenic profile, in which the PERSIST-2 study and the PAC-203 study and ongoing Pacifica study that's currently evaluating this approach has data for salvage in the second-line setting. Now, momelotinib was approved, as I mentioned, in the US at the end of September. This was based off of the MOMENTUM study, which was a pivotal registration phase 3 study comparing momelotinib to danazol in patients with myelofibrosis treated with ruxolitinib with ongoing symptom or spleen burden and anemia. The study, as a primary endpoint, was positive for symptom improvement, which was superior with momelotinib compared to danazol, but also for spleen response and was non-inferior for anemia response. So this was a trial that demonstrated a safety profile for patients with myelofibrosis treated with momelotinib over a 48-week period and demonstrated the capability of momelotinib to allow for transfusion independence in at least a third of the patients on this drug, and data that's suggesting that patients who have an anemia response with momelotinib are more likely to enjoy a survival benefit with this drug. The approval for momelotinib was also based off the SIMPLIFY-1 study, which was conducted many years ago in JAK inhibitor naive patients comparing momelotinib to ruxolitinib. In that study, the drug was not superior to, was not inferior, I should say, to ruxolitinib in terms of spleen response, but was inferior to ruxolitinib in terms of symptom response. Nevertheless, there was an anemia response that was also seen with that study, and post-trial analysis demonstrated a survival benefit associated with that anemia response. I think collectively what we can say is that there are 4 JAK inhibitors that are approved that allow for niches to determine treatment. Thrombocytopenia particularly drives the use of pacritinib. Anemia may drive the use of momelotinib, but there's also data for pacritinib as a very potent ACVR1 inhibitor in terms of anemia responses, in which 25% of the patients attained a clinical improvement in hemoglobin in the PERSIST-2 study. So there's 2 options there. And then fedratinib is an excellent choice, second line for ruxolitinib failure. There are some differences, probably based on the kinome profile, that may explain differences in toxicity profiles. So one should be aware that Wernicke's encephalopathy is a black box warning for fedratinib. This is a very low frequency in the clinical trial data set that we have, and easily addressed by checking a vitamin B1 or thiamine level at drug initiation and every 3 months and repleting if necessary. Rarely a reason to discontinue therapy. Both fedratinib and pacritinib are FLT3 inhibitors, and for that reason, you see slightly more GI toxicity, nausea, vomiting, and diarrhea, usually in the first 2 cycles. Very easy to handle in about 40 to 50% of patients with an antiemetic up front, antidiarrheal if needed, and typically resolves within the first 2 months. Again, rarely a reason for discontinuation. The ability to sequence these drugs also provides other options for patients, particularly in the community. One should keep in mind that a JAK inhibitor could be used as a bridge to transplant in transplant-eligible patients. So to reduce the spleen, improve performance status, and reverse cachexia prior to a transplant should always be a consideration. A lot of thought and research is going into determining the optimal time to introduce transplant to someone who's responding to their JAK inhibitor. It is likely that's when they are responding optimally. That's often the hardest time to convince a patient to move to transplant. The definition of ruxolitinib failure, which determines clinical trial eligibility and further research in this area, has yet to be universally consensus determined. The field has moved on now, is moving on, I should say, to combination therapy. So we are very excited for ASH 2023 in San Diego to see the results of the Transform-1 study, which is navitoclax, the BCL-2/XL inhibitor, in combination with ruxolitinib in the upfront setting in JAK inhibitor-naive patients, and pelabresib in the MANIFEST-2 study upfront in the JAK inhibitor-naive patients. So for the first time, we're looking at combination treatment approaches with rational agents that synergize with ruxolitinib early on to get the deepest response possible, hoping that that will ultimately translate to more durable enjoyment of benefit with ruxolitinib and a prolonged time to discontinuation, improved progression-free survival and overall survival, which will need to be determined over time. We'll also look forward to upcoming studies with selinexor, which is going to be which is an XPO1 inhibitor, which is going to be evaluated upfront as well, which has compelling phase 2 data, and navtemadlin, which is a very potent MDM2 inhibitor, which activates the p53 pathway, which has a wealth of both translational data and clinical data that providing confidence that this approach also is anticlonal in its mechanism, and may be best used in combination with ruxolitinib in a salvage setting for patients who have a suboptimal response to ruxolitinib. These are patients who don't have the regulatory endpoint of SVR 35% or TSS 50% reduction, but don't have progression of disease, don't have a 25% increase in spleen volume or progression or evolution to acute myeloid leukemia. So this is a trial that's upcoming, adding navtemadlin to ruxolitinib to salvage these responses and improve upon the outcomes of patients. So there's a lot that's being done, and a lot of drugs that are moving along earlier on, such as TP3654, which is a PIM1 kinase inhibitor. Again, ultimately, I think these drugs will be best used in combination, and we'll need to see combination data with the other JAK inhibitors, not simply ruxolitinib. So it'll be nice to see data in the future with momelotinib, with fedratinib, with pacritinib. Again, being able to position combination treatment approaches in order to afford greater, deeper, and more durable responses, which is incumbent on us as clinical investigators to demonstrate in long-term follow-up of these clinical trials. So I do feel excited about the future of clinical development and drug development in myelofibrosis, but the current state of standard of care are JAK inhibitors, single agent, upfront, with combinations in clinical development. I should mention luspatercept, as I said, for anemia, also an independent study as an agent to offset both disease and treatment-related anemia in the setting of ruxolitinib, is also an important study. So there are a lot of efforts to optimize our delivery of JAK inhibitors, and for JAK inhibitors that are commercially approved in the US, available for patients with myelofibrosis. Thank you.